So look, I'm Westmead Hospital, and I'm really speaking from that perspective. So we're sort of moving to the other end of the microscope now. The first time we saw an epidemic like this in the absence of significant host immunity was probably swine flu, which, as you know, are a combination event we think led to something that emerged basically as a pandemic and arrived in our winter season in Australia and New Zealand. So we were the first one to have a classic flu season with the new virus. The initial attack rate was very uncertain. It felt to me at the bedside very much like the start of this. A lot of questions, not many answers. We learnt that subgroups are at very high risk: pregnant women, obesity, and those with significant comorbidities. And we saw the same kinds of chest x-rays that you see when you get horrible viral pneumonias. So for those of you who aren't familiar with the chest x-ray, I've sort of drawn a heart and diaphragms in there. The red bit's the heart, and I've outlined the bits that are supposed to be black, which is where the air's supposed to go. So if you look like this one on top, you really need someone to breathe for you. And of course, that means the mortality is strongly determined by the capacity of your health system. The other thing that was different about flu, as I said, we had a lot of problems with pregnant women. They made a significant proportion of our hospital admissions and our mortality. And of course, without maternal antibodies, we saw a lot of disproportionate infant disease. And this doesn't appear to have been the case with COVID, which is what the clinicians call it, the SARS-CoV-2 infection, because although we get the usual suspects spreading it, that is to say the mobile part of the community, they're not represented in the mortality figures. So if you look at this big study of 170,000 out of the US, nobody under 19 was admitted to ICU or died. And if you look at the tiny proportion of those people in the elderly population, they make up a disproportionate amount of the deaths. So this is sort of what you see in these kind of respiratory infections, but we have that different behaviour with pregnancy and the youth. So compared to the other coronaviruses, the original SARS-CoV Eddie mentioned, I'd point out a couple of things. We often talk about case fatality ratios, and we talk about transmission data, which I've got here as the R0. And these figures are all useful for public policy planning, but they can be very misleading when you're trying to understand the biology of the virus. To illustrate that, you can look at the reported mortality of this virus between 1% and 7%, depending on the country. We're running at about 1.4%, and it very much depends on your health system, your health structures, your populations, and so forth. So I guess the message is that you have to take these data with a big pinch of salt. The R0, the transmission rate, so if every case leads to another 2, that's an R0 of 0. This is essential for public policy planning, of course. And we think that SARS-CoV-2 is probably behaving much like swine flu did. So Eddie mentioned the ACE2 receptor. That's led to a bit of whispering in the clinical corridors about ACE inhibitors. You know that we use drugs to block the ACE receptor binding in humans to manage things like heart disease, blood pressure. We use it routinely in diabetes. So all those people who are dying in this pandemic are those people who express ACE2 receptors very vigorously. And there's been some question about whether we should stop using those types of drugs. There's no clear evidence that it does any good, and it might do some harm, perhaps because we're intervening too late. So that's an open question. There's an assumption, or at least a lot of question marks about the inflammatory nature of this illness. So a lot of the clinicians see this as a more inflammatory disease. It's, behaves a bit like a macrophage-driven disease. I refer you to a nice review of the topic if you're interested in this side of the physiology, but the implications at the bedside relate to the risk in pregnancy, the risk for neonates, and particularly the clinical interventions we can offer, the so-called ECMO, which I'll come to in a minute, and the idea of immunosuppressive therapies to manage this infection. So the clinical perspective of this, or at least an immunologist's perspective, hence the little plasma cell with spectacles, is that it starts at a viral response phase, which a lot of the younger community don't seem to progress beyond. And that's where drugs like remdesivir and perhaps future antivirals may have a role. It's pretty clear that the anti-inflammatory activity of hydroxychloroquine, notwithstanding the high-profile exponents of it, has been really rejected and discarded. It is still in some clinical trials, but I don't think many people are taking that as a very serious option. There's no doubt that the progression to severe disease is heavily filtered through host comorbidities and host immunogenotype. The latter is an area of, obviously of great interest, but the former leads to a huge amount of confounding variables that make the clinical data very hard to interpret. If you wanted to do something like look at the genomes, look at the clinical phenotype in relation to where those genomes were taken and try and make sense of it, you have to be very careful with the clinical data. The idea of using convalescent plasma is talked about, but there's some reason for skepticism about that. What may be useful is some sort of direct immune suppression, and this sort of thing is being trialled at the moment in clinical trials. In terms of what we can do if you get to the point that you really fail, is this is single organ disease essentially in humans, and we really only see one major organ failure. And we're used to supporting that for a variety of reasons. Occasionally we can get to the point where no matter how well you support the lungs so that the heart can, bring in the blue blood and circulate it through and make it red and pump it out again, you get to the point where if you get enough inflammation and make that little delicate lining between air and blood too thick, oxygen simply can't diffuse effectively across it. And it gets beyond the capacity of even modern mechanical ventilators to replace that function. And so that's where sort of more sophisticated intensive care support makes a difference, because it's pretty clear that a lot of the disease we're seeing appears to be more shunting microangiopathic type of disease. And there's a lot of talk about whether what we're seeing is really pulmonary microvascular disease. And many open questions about the physiology still there. And the physiologists who look at it from the lung perspective roughly divide it into a couple of different phenotypes. So you have the phenotype that classically presents with lungs that you can support with a mechanical ventilator, with the classic peripheral disease, good perfusion through the lungs and good compliance, but disproportionate hypoxia. So a lot of shunting of blood through unventilated areas. And that's thought to be a bit of a vasoplegic type of phenomenon. The classic life-threatening version of this disease, which many people then go on to, is a very stiff lung with very extensive disease, and essentially the blood goes through without meeting oxygen. And this can't be effectively supported by ordinary mechanical ventilators, which are widely available in hospitals all over the world, and they need more sophisticated support. And this kind of sophisticated support is the thing that functionally determines ICU mortality in countries that can afford to manage it. A country like Australia, if you come into an intensive care here with a severe viral pneumonitis, you're likely to be placed on essentially an artificial lung, which will oxygenate your blood for you while your lung recovers from the injury. And we learnt the value of this during swine flu, and it's truly a life-saving intervention. But we do know that if you have the sort of disease that is likely to scar your lungs, in other words, an inflammatory disease, then you don't get effective lung recovery. So the only point of doing that in that scenario would be to replace the lung surgically with a transplant. And that means you have to have good physiology, because a lung transplant is not for the faint-hearted. So if you've got a disproportionate influence on the elderly and those with comorbidities, this is not the community that you're going to be successfully rescuing with transplantation. So the whole role of intensive care support, advanced intensive care support, is uncertain, but certainly if you're in a place with an overwhelmed system, you will not get to that point. So we see some places reporting intensive care mortality of 50%, Other places reporting intensive care mortality of 15%. And that depends really on your system, who you're admitting to the unit, and how you're determining who gets what therapy. So that's what we can do in intensive care, but what about at public policy end? I think this is a nice little illustration from Iceland, you know, a country of 360,000 people, a third of whom live in the capital city. And you can see the impact of the migration in with infected patients, the purple section, and then you can see the takeoff in family spread and community spread that follows thereafter. And the difference, if you can intervene to stop that secondary transmission occurring, and that's been the entire focus really of public policy. And we know that this concept of the lockdown and the social distancing, you know, a phrase that's moved into everyone's lexicon now, we've known about this for 100 years. It was well illustrated in the original 1918, you know, Spanish flu epidemic, where the difference between two cities that had totally different public policies was reflected in their mortality rates very directly. And so this leads to this idea of, you know, keeping your distance everywhere you go. You know, you queue up at Bunnings to buy a can of paint and you have to stand on the little white X. This is all about the idea of how far a droplet will spread. We know that you need to get probably less than 5 microns to get nice rain out in the alveoli. But beyond that, the big heavy wet droplets that contain a lot of infectious virus and only need to meet your conjunctiva, that means your eyes, nose and mouth, they rain out in about 1 metre or so. And that's where this whole 1.5 metre, 2 metre business comes from. Some viruses like measles spread like crazy in small droplets. Other viruses much less efficiently. And we're not quite sure where this is behaving, but it's probably looking a bit like you would see flu. So you need a decent inoculum probably to infect someone. This is the curve that we're trying to flatten. The first Victorian case came in on the 25th of January, and then everyone sort of couldn't buy toilet paper on about the 3rd of March. And now the shops have got toilet paper, so I guess everybody's relaxing because the curve is pretty flat now. And I think everyone's seen these figures. This is all over the place. And I think we're one of the lucky countries because we're relatively wealthy. We haven't been hit hard. Our system, despite our original concerns, has not been overwhelmed. And because it's relatively easy for us to close borders. It's just really airports and ships. And of course, we stuffed up the ships a little bit, but, you know, it's relatively easy for us compared to, say, you know, Italy or Spain. Nevertheless, a combination of public policy and wealth has seen us through. Areas like Africa and parts of Southeast Asia, we're all very worried about what's going to happen there, and I think some of that is yet to be seen. There's no doubt that if you look at a place like Afghanistan and try and control something like this in a crowded camp there, I think you'd have no chance. We know that the impact of ordinary behaviour like hand hygiene can be quite dramatic. This is a bit of a modelling study published presciently and widely publicised in the UK, based really on flu dynamics, but essentially showing an enormous impact from a catastrophic outbreak just by people increasing their hand washing frequency to the level that a clinician would normally do, which is very frequent, 5 to 10 times a day typically. And in terms of hand washing, this is important because people often ask about this and you get people making crazy solutions. The punchline is because these are simple enveloped RNA viruses, a bit like flu, although they're very different to flu obviously, but the same kind of outer membranes you're dealing with, it means that, you know, oxidizing agents like chlorines and bleaches and that sort of thing, alcohol and detergents all work pretty well. So that the stuff you clean your lab bench with, you know, a bit of 70% ethanol does the trick very nicely. The fancy stuff with the pink chlorhexidine in it has no added benefit for this particular agent. But in terms of what you choose, the common sense rule for clinical people has always been, if you can see muck on your hands, you need detergent. If you can't see muck on your hands, alcohol probably works better. And making proper detergent-based hand washing work, is actually much more time consuming than a quick slop of alcohol. So clinicians use a lot of alcohol and very little oxidizing agents because it's hard on skin, and very little detergent because it takes too long and people don't do it properly. To get people to do this well is difficult, but if you can just take a quick squirt from the pump in the Bunnings or the Coles, you've got your hands nice and clean. We've seen a lot of deaths amongst healthcare workers, as you'd know, and probably the figures are that as much as half of these deaths may actually be due to healthcare worker exposure, so at work exposure, contamination by patients. And what we use basically is simple eye cover, because the conjunctival membranes of your eyes are an important entry point, and simple face cover. And then it's common sense. It's cover your clothes, cover your hands. We do this for heavy clinical exposure. And we make a point of making sure that people know how to do this, because we know that people do it very badly. We know that incorrect PPE use, even amongst clinicians, is very common. And simple studies with highly contagious materials show that up to 40% of apparently trained healthcare workers will self-contaminate. And so that's why we make a big deal about training for PPE. And that's why wearing a spacesuit to work, if you're worried about COVID or you're dealing with COVID, is not necessarily the right thing. The message about PPE, if you work with this, or in fact any other dangerous virus, is training. Training is essential. Why does everyone disagree about public face mask use? It's because people don't know what to do it. You wear a face mask and then you stick your fingers in your eyes and you don't wash your hands, and your face mask doesn't work because it gets breath contamination and becomes saturated. We think it gives a false sense of security, and so that's why it's not advocated widely in Australia. It is advocated in some countries, but many, as I say, experts disagree, and that's why there is disagreement. What about testing? I've got 2 slides to go, Marcel. Is that a thumbs up, or should I wind up? No, it's still going. Okay, so what testing do we do and when do we do it? We learnt from flu that people who come in with a wet face, the wet face is where you take the best samples, and the trick is you've got to get the respiratory epithelium, so that it means if you have untrained people doing swabs, so your friendly local GP, your friendly community nurse, you've got a biological sampling problem and a significant false positive rate. So again, when you look at studies and you want to do, if you wanted to do, say, a GWAS and look at sampling rates to get a feel for prevalence, you really need to understand who's doing the testing and how it's being done. We know that when you present with deep disease, whether it's truly biphasic or not is unknown, but we know that if you're crashing into the intensive care, a sample from your lungs is much more reliable. Notwithstanding the uncertainties about the phases of illness, we do know that prolonged shedding of at least detectable RNA is common in influenza. We know that about 10% of people who get treated for influenza start shedding resistant virus, but they don't appear to be infectious. So we don't really know what it means when you've still got a bit of COVID RNA in your sputum. We know that your face cleans up before your lungs do. We know that from our intensive care patients. And we know that your PCR remains positive for many, many days. Perhaps just shedding RNA, perhaps shedding real virus, but after your cultures, deep cultures, become negative. So we don't know if there are any reservoir sites as such. And the concept of the super spreader is probably more about behaviour than physiology, but obviously everybody's got a different immune system. It's natural that there are going to be some people who are going to truly shed more than others. Pre-testing is misleading. This is really a message for clinical people, so it doesn't matter so much for this audience, but again, it's a false sense of security question. Serology is available, and this is what's going to tell us what our real infection rate. We learnt from swine flu that about 20% of the country got infected, and so we realised that the true mortality was only 0.1%. We thought it was much higher when we were experiencing it, but it was actually only about 1 in 1,000. A lot of subclinical disease. We're seeing a lot of subclinical disease in the youth and in children, and they may not be important transmitters. So that's why there's talk about releasing kids back to school. We think they don't get sick, and we think they don't spread it much. Sequencing, much contention about available sequences. There's a couple of hundred on GISAID now, and there's a couple of hundred more coming from Westmead. There should be complete sequences. There's some incomplete sequences out there. The health authorities tend to be a little bit precious about releasing sequences that they think can identify, because some people think this is a bit of a fingerprint that you can use to track people, and in fact, it's exactly what it's used for in the public health meetings, of course. Most labs run tests now. There's some cheap and cheerful things available, and very good quality commercial tests becoming available. We still use an in-house test at Westmead in big batches, and there's been a lot of people tested. So look, I need to wind up, I think. The public health systems are what determines the spread. I think that's the fair summary. If you're in a rich country with strong public health, you can do public policy well, you'll control this. What you can do as an individual, it's all about face and hands. It's not so much about testing. Testing is for public health information. In terms of clinical management, we're not sure what to do with our fancy intensive care units, but there's no doubt it's determining the fatality rates. And steroids may be important. Antivirals, we're not sure. Pregnant women seem to be relatively safe from this, although the vascular dynamics may even be protected. We don't know. And I've talked about the children. So big questions for us. We don't know the true denominator yet. I've hammered that message, I think. We don't understand the host determinants. In terms of interventional stuff, we're not quite sure what to use. We're not even quite sure when to clear someone at the moment. At the moment, we're relying on just having a whole bunch of negatives. And we really don't know the role of vaccines in convalescent serum. So Marcel, I think I should stop there and check if there's any